Okay, it is now 2 o'clock. Good afternoon, everyone. Thank you very much for joining this session. Just before we begin, for those of you who haven't been in attendance on any of the other webinars, if you have any questions during this webinar, please post them in the Q&A pod as opposed to the chat pod, and that will make sure that we can answer as many as possible at the end of this session, and also get back to any of you chance to finish off the Q&A before this session is due to close. I hope it's helpful, and Louise, Julie, if you want to make a start on the session.
Lovely, thank you, Emily. Yes, I shall crack on. So my name is Louise Davison. I'm a Senior Assessment Manager within the healthcare at UKAS, as indeed is Julie, but Julie will introduce herself later when she takes over this presentation. Just to point out that we will be recording this session and it'll be sent to all participants shortly after the end of the session, just in case you miss anything. Similarly, as Emily says, we've got a particular pod for queries as opposed to the chat. Just make sure you put your questions and answers in the query pod. Unfortunately, the way this Zoom meeting has been set up, you can't actually see the questions that other people are asking, which is a bit of a shame. But you know, we are where we are, and we'll just use it as it is. So at the end of this presentation, we'll go through any queries that are outstanding, and we'll actually read them out so that you're aware of what question we're answering. So this particular Zoom meeting webinar is for sampling providers only. There is information relevant to testing, but essentially if you're a provider that provides COVID-19 testing as well, you're probably better actually attending one of the other webinars. And I think the last webinar on testing is Friday afternoon. So we do have 2 more webinars on Friday afternoon. I think the morning is sampling again, same repeat of today's webinar, and the afternoon will be for testing. So what we're going to be covering this afternoon. So first of all, the background of why UKAS have been involved in the private provider COVID-19 testing. We're going to go through a review of the 13 stage 2 UKAS requirements and how to conduct your gap analysis, just to give you some tips on that and what we expect to see, and also our expectations for evidence submission. We'll go through the evidence submission timescale and what happens next, and then we'll go on to the question and answers session. So I'm sure a lot of you have done these webinar or video meetings where you're given a presentation and you can't actually see who you're speaking to, which is all rather strange. Sometimes we get to see who we're talking to and sometimes we don't, but today I can't see anyone. So I'm hoping everyone's paying attention and listening. And I've got to apologize actually for my background, because this isn't honestly my chosen wallpaper. I'm actually not in my own house at the minute, so I apologize profusely. I've got a nice plant and I'm not really hiding the alcohol behind me at all. So anyway, crack on. So UKAS, who are we? We are the UK's national accreditation body and only accreditation body. We were established in 1995 by government as a private company limited by guarantee. And we were appointed as the national accreditation body by the Accreditation Regulations 2009. We are independent of the government, but we operate under a memorandum of understanding with the government department BIS. We have a duty to act in the public interest, so we're commercially aware, but we're not commercially driven. Just to allay any fears that this is essentially, a money-making activity for UKAS. That's not the purpose of it. EU Regulation 765/2008 provides the legal framework for accreditation. And accreditation is recognised as a public authority activity. What is accreditation? It's the recognition of competence of organisations to perform specific evaluation tasks such as calibration, inspection, testing and certification. And so essentially that's why the Department of Health have asked UKAS to get involved in this process, because we are demonstrating competence for sampling and testing. We're slightly different to the CQC in terms of that we're actually looking at competence for specific activities. Next slide, Emily. So you're probably very aware that there are 3 stages for private providers of COVID-19 testing. The first stage, which I'm guessing all of you or most of you have already been through, is the self-declaration on the DHSC website, and where applicable, the UKAS application for accreditation. And I'm assuming that everyone that's participating today has applied or will apply, because if you don't need to apply, which some providers don't, then you don't actually have to go through this process. An easy explanation of who doesn't have to apply is those, if anyone is not actually taking the samples yourselves as an organisation, but you are expecting the patient to take the samples, and you're not doing any testing, then you still have to self-declare to the DHSC, and we will review that declaration, but you don't actually have to apply for accreditation. And there may be some of you that have self-declared and you've got inquiries from DHC and they haven't actually approved you yet. And that may be one of the reasons that sometimes the self-declaration hasn't been entirely clear on whether you're actually carrying out the sampling yourselves or whether it's self-administered sampling. So once you get through the stage 1, your self-declaration is reviewed and approved by ourselves, and you apply for accreditation as required. We inform the DHSC, and it's DHSC's responsibility to actually make sure that you're on the approved website for either general population testing or TTR, or of course both. So the next stage is stage 2, which of course we're talking about today, which is the UKAS appraisal and assessment process. And then the next stage, stage 3, now this slide is slightly misleading because it says accreditation granted. The next stage will actually be an initial assessment, where we do a much more thorough assessment of your activities than we're doing at stage 2. This isn't the way that we normally handle applicants for accreditation. It's basically a cut down version of what we normally do. Normally at this stage we would be doing a pre-assessment for anyone who's not been accredited before, which is a much more thorough process of assessment before you actually go forward to your initial assessment. There are a number of reasons why we've taken this route. It's partly because we're aware that a lot of you really don't have any experience of the accreditation process, so we're essentially making it simpler, giving you a bit more guidance. It's partly because essentially we've had so many applications that actually to go through the whole full pre-assessment process would actually demand resource that we don't currently have. It's also actually to keep the cost down, because obviously you are being charged for this process. You will have paid your UKAS application fee. You will be paying, I think it's an agreed half a day of UKAS assessment time for your stage 2 appraisal and assessment, and then you will be charged for the initial assessment. But essentially, if we were going through the whole pre-assessment process, it would actually be costing you a lot more. Okay, next slide, Emily. So what are the 13 key requirements? I'm sure you'll have probably seen them on the UKAS or the DHC website, but we'll just go through what the requirements are and the type of evidence that we're expecting you to submit. So first, very importantly, is to buy the relevant copy of the ISO standard. Whatever you've applied for, you need to buy that standard. The normal route in this country is to buy it from BSI online. You also need to have conducted your gap analysis, which obviously Julie is going to talk about more later on. In terms of what we accept for your gap analysis, we do expect it to have been done thoroughly enough. So, for example, if the answer to every question was no, but with no actions defined or timescales, we would come back to you and say, well, you know, you're not compliant, what are you going to do about it? I think if the answer was yes to everything and no justification, we'd probably come back to you as well. But as I said, Julie will talk more about that shortly. The second requirement is to define your organisational structure with reporting lines and responsibilities, and make sure that whatever documentation you submit covers your clinical governance reporting. structure. So, for example, who's responsible for clinical governance? And just bear in mind, because you are taking responsibility for the end-to-end process, that you are also responsible for making sure that you have those adequate communications with your laboratory, for example, in terms of if you have any problems with samples or patient data, then those issues get passed on to the laboratory to make sure that they're aware. If they have any issues such as a problem with the testing, or it turns out that you get a complaint that you've issued the wrong results, then all that kind of thing needs to be accounted for in your governance structure and how that's managed. You need to have adequate liability insurance. Now, something I should have pointed earlier on in terms of what UKAS's role are. We can't actually give consultancy. It's a very important part of UKAS's responsibilities that we assess, but we can't give consultancy. We can't tell you what to do exactly, because then when we come in and do the assessment, we would just be assessing against what we've told you, and that wouldn't be independent. So although we can provide training sessions like this, we can give general guidance, but we can't, for example, tell you what liability insurance you should buy or advise on that. You essentially need to make sure you may already have liability insurance. You may need to still buy it, but you need to make sure that it covers your scope of activities, etc., including, of course, COVID-19 sampling. You need to have access to relevant clinical expertise. Depending on whether you apply for 15189 or 17025, there are less requirements in 17025, but certainly for 15189, you need to have the relevant clinical expertise. Now, if, for example, you're a private GP surgery that have applied, you've got that clinical expertise probably there already. It's very easy for you to cover. If you're a different sort of organisation with, for example, no medics on your payroll, then you may need to contract that expertise in, and we'd expect to see that individual or those individuals were identified and contracts demonstrated for those individuals. Okay, Emily, next. You need to have sufficient trained and competent staff. Now, bear in mind that we will ask you for your training and competency procedure and an example of your a record for an individual that's been trained in and competency assessed for, normally for sampling, is what we will ask for. So training is how do you actually train your member of staff to do sampling, for example, or how they do reporting. And then competency assessment comes after training. How do you actually competency assess someone is competent to do that procedure? For example, would you witness them taking 10, 20 samples? Would you check 20 reports that they'd sent out? That kind of thing. On your procedure and record, we expect you to have objective criteria against which you're going to assess staff for competence, and also when you record that competence, for example, witnessing, it needs to be objective. So, for example, witnessed by so-and-so taking 20 samples. Now, something that you might not have expected to have to supply if you're only actually applying for accreditation for sampling is validation of technical methods and demonstration that they can achieve the performance characteristics required. So the reason we ask for this, even though you're not actually doing the testing, is because you have declared responsibility for the end-to-end process. So we need to ensure that you have made sure that your laboratory, whoever you choose to do the testing, is actually doing the testing according to the required level. So, for example, this is sorry, I should have said this is particular to TTR. There are very specific requirements for TTR testing that the method needs to achieve, and that validation has to be done by an independent organisation, for example, a PhD or an accredited laboratory. So, for example, the test has to be sensitive to at least 97%, specific to at least 99%, and it has to have, a specified minimum number of samples. What we also need to see, whether it's testing for test release or general population, is that your laboratory has verified the method, and that means that they've proved that the method works in their hands. But both of those types of evidence you will be able to get from your laboratory. Your laboratory will also have applied to UKAS and have self-declared, will also be providing that information, but you need to actually get that information from them make sure it's okay and submit it to us. It's not enough that you just tell us we're using such and such laboratory and that they are on the approved list. Number 7, you need to have documented procedures for sample collection, pretty obvious. Transport, in terms of how you transport that sample to the laboratory, make sure that you cover, how you make sure that you meet UN 3373 packaging requirements. Also storage, if you're storing your sample for a couple of hours, if you send them off once a day, whatever, under what conditions do you store your samples, what temperature, what's the maximum amount of time you can actually store them before you send them off, that kind of thing. Number 8 actually shouldn't be on this slide because it's not applicable, and it does actually say on the form that you will submit to us that IQC and EQA isn't applicable to sampling, provided you don't need to submit us that evidence. Emily? Next thing you need to prove is that you have facilities that meet relevant containment level requirements, and that you appropriately manage and monitor your environment to prevent cross-contamination. And we're talking about cross-contamination that could affect the testing. So, for example, do you need to do regular swabbing to check that your work surfaces aren't contaminated with COVID-19 or anything else that may affect the test? What procedures do you have in place? What PPE do you have in place to make sure that obviously staff are safe, but also that the samples don't get cross-contaminated between one sample and the next, etc. You also need to have appropriate interpretation criteria for your results and your reports. You need to demonstrate to us, supply a procedure for how you report your results, both for positive, negatives, for TTR, for general population, and you need to define the format that you will report your results to patients. You need to demonstrate and document who is actually authorised to report those results. And again, that goes back to your training and competency, that those individuals we will also expect later on to actually see their training and competence records. Number 11 is that you need to demonstrate you've got appropriate procedures in place to ensure TTR testing, obviously specifically, is performed 5 days post self-isolation, that you meet any other agreed turnaround times with your customers, and that you report in accordance with the statutory regulations. So how do you demonstrate that you collect all the information from the patient that you need to collect? How do you actually report positives to the PHE? And something to consider is, are you reporting to the PHE or is the laboratory reporting to the PHE? If the laboratory are, then you need to have very clearly defined and agreed roles and responsibilities. Because you're taking responsibility for the end-to-end process, it's probably fine that the laboratory are doing that reporting, but you are still responsible for making sure that they do that reporting according to requirements. Emily. And the last couple of things, you need procedures in place to resolve and report adverse incidents, including clinical incidents. So, for example, as we talked about earlier with the clinical governance, if you get an incorrect report going out, or if it turns out that the lab have sent you an incorrect report, how do you record that incident? What investigation do you do to find out exactly why it happened? What actions do you need to put in place to make sure that it doesn't happen again? There are lots of examples, but it's not just about health and safety. It's also about incidents that have the potential to affect the results, and therefore, of course, have the potential to affect patient management. And lastly, you need procedures to safely dispose of clinical waste, which I think is fairly self-explanatory. Obviously, you need to dispose of your clinical waste according to national guidance and regulations. Okay, I think we're on to passing over to Julie now for the gap analysis.
Hello, I'm Julie Rogers. I'm one of the Senior Assessment Managers at UKAS, and I've been working with the GHSC and plenty of customers at the moment, and our aim really is to help you understand how to complete the gap analysis in this section. So we're going to go through some examples. They're not real examples, they're dummy examples so that you can see the type of thing that we need to do. I'm going to basically help you through that process so that you can understand how that's useful to yourselves in progressing through the different things that you need to do to get through that stage. And this stage is to make sure you remain on the list for the DHSC and to ensure that you're progressing towards actually getting your accreditation. Okay, thank you, Emily. So we have a gap analysis provided to you. We have revised it and the current one will be on the website if you look at that. But fundamentally, it is the main clauses of the relevant standards. So we've got parts at the bottom for 15189 and 22870. So if you're providing sampling, you can choose that standard or you can have 17025. 15189 is specifically for med labs. And we're encouraging you, if you think you will in the future do point of care testing or you're going to do further work for sampling for different things, that you apply for 15189. We've got a set of clauses listed down the first column, and then the management requirement or the technical requirement in the second column. And basically that is the header for the requirement in the standard. So it's just a brief heads up of what we're talking about. And then what we would like you to do is to list the relevant internal document and identify whether you're ready or not for assessment for 15189 or 17025. So we've set up a RAG scoring in the column saying documentation meets requirements, where you will basically go through and identify how far you've progressed. What we would like you to do is use this to be a progress map for you to go through all the requirements and see how far you are and work through that in a systematic and staged way. Next slide, please, Emily. So the gap analysis is a process that is regularly used for comparison of standards and to develop systems to meet requirements of different kinds. In this instance, we're looking to see where you actually are now and where you need to be. So it's identifying the gap in the management system that you've got to fill. The idea is really that once you've completed it, you've got an overall picture of where you are. You're able to focus your resources to plug those gaps, and you can monitor that progress because we've got quite tight guidelines for this. What we would suggest is that you carry out your gap analysis alongside writing your draft quality manual, because things are common to both. Thank you, Emily. So this is the form we've talked about. And this is an example for 15189 for pre-examination processes. Of the sample collection, this is the part that relates specifically to sampling. In this, there are several clauses that relate to the pre-examination clauses, and we've listed those so you can have a look at those. Can we have the next slide, please, Emily? When we look at the actual standard, there's much more information in relation to what is required than is indicated in our gap analysis. So we definitely listed all of the clauses. This example is 5443 instructions for collection, and you can see that we've got quite a list of things that you need to identify whether you're meeting or not, and identify the gap or not. So that gives you an indication that you will need to look quite detailed at what is in the actual standard as well as what's in the gap analysis. Next slide, please. So in this is a worked example, and this is totally manufactured. So it just gives you an idea of the types of things that you could enter. So here we haven't filled in all of the lines, but clearly when you go through your gap analysis, you have to look at every item on the list. And for these ones, we've just picked some that you can see them on the slides and not be too busy. So for the first clause, 542, which is information for patients and users, This dummy customer has said they've got that information in web page 06, but they know they don't meet their requirements, and they've said that they would like to revise that to meet the requirements. They've given an identification of who's going to do that and what they're going to do with a target date. Now, this form, we have set it up in a way, it's not totally fixed in how you do it. If you put yes, you don't need to do actions, but if you want to, you can say what you've got in place so that it helps you progress and track what you're doing. We've got a target date for action for that, and when that was to be completed, that would be filled in. On 543, the request form information, they've identified that's in request 01. They think they meet requirements, and they've said that. They've said the request form includes all of the requirements, so they've checked what's in the standard in detail, and they've put that as completed. Instructions for collection activities at the bottom, 5443, we've got two documents identified as covering that, and they think they've partially completed that because they know in A, C, D, E, F, and H, they meet all the requirements. But what they have identified is that patient sample suitability is checked, but they don't have all the criteria required, so they need to update that procedure to cover that. And G was a question around collection, storage. They basically said that doesn't apply to them because they test at collection. So this may be a POCT provider that we were thinking about here, but you're unlikely to do that. But you know, things will not always be applicable in every instance. And we have got a vast majority of people doing sampling, but lots of people have different models, even for that. So go through it and think about where it's relevant. Next slide, please, Emily. In 17025, which is the generic testing standard, so that standard can be used for any type of testing that UKAS can accredit. But basically, the standard that requires the sampling is 7.3. It is very similar to what is required in 15189, but if you are using that standard instead of 15189, that's the relevant clause. Can I have the next slide, please? So in this example, 731, the requirement of the sample plan and method, there is dummy customer has sample 1 as the relevant procedure, and they've said they meet requirements because they've got sampling processes documented in that procedure, and the sample plan is all patients are to have the same sample type of nasopharyngeal sample taken. This is a generic standard, so it might be that they're testing bulk flour in this standard and they need a sample plan to say how they would test that. In the medical instances, it's fairly straightforward. So just clarify what you're doing. So for 7.3.2, sample method, they've covered and they're happy with that. In terms of records of sampling, they've had a look at 733 and they've decided they're not compliant because they've looked at that list and said, we know we don't keep all of that. What we need to do is review it and say how we're going to keep it. So someone has been given the task of updating and reviewing the information with a target date. We don't expect you to have completed everything at this stage. For stage 2, there are some critical things. We do need to see you are using the correct testing if you are doing test to release and certain things are in place, but we're not expecting you to have totally done everything ready for the next stage. Next slide, please, Emily. For reporting, some of you may be reporting, some of you may not, but effectively, there are specific requirements for reporting in the standard for 15189, and similarly, there are for 17025. And these requirements are detailed not with initials in this standard, just a list of things that you need to do. Next slide, please. And the sub-clauses relating to reporting, there are a number of those. And for this example, we've looked at 582 and the dummy customers said that they've got that in report 2. They still have to assess what they've got and whether they meet requirements, so they've put no. And then the report contents, they're partially addressed. The reports to patients don't have all the required aspects. So there's work to do in this example. And obviously, you're going to need to consider the reporting, as Louise has said, in the wider context, because you are maybe reporting to individual patients, you may be reporting to another organisation, or you may be reporting to the PHE. But all of those things are requirements that you need to consider when it's relevant to yourselves. So to make sure that the reports are appropriate for wherever you provide them and meet the requirements. Thank you, Emily. Interlaboratory comparisons is an example of something that, if you're just doing sampling, isn't going to be relevant to you. This is a requirement where the testing is assessed independently to see that the results are valid. So it's irrelevant to the overall testing process, but not specifically for someone that's just doing sampling. Next one, please. There, we've got in the example that the dummy provider has said they don't think it's applicable because they don't actually do the testing themselves. They've said who they refer the work to, and that's appropriate for that type of customer. Next slide, please. So some things are apparently not relevant when you first glance, but please do carefully check. As Louise has said, it may be that you do have environmental conditions that you need to monitor. For example, if you're keeping things in a fridge, it may be that there's a specific temperature range. And so do read carefully what is required. I appreciate that most of you are not actually a laboratory if you're just doing sampling, but this is a generic standard, so it talks about a laboratory. But if it's relevant to you, if you're doing something that falls into those clauses, please consider them and think about that. Next slide, please. So for in this example, 526, the facility maintenance and environmental conditions is documented in this dummy customer's facility 02. They're partly required in the first example because they've identified that they've got well-maintained facilities, everything else is fine, but they don't actually know what acceptable storage range is for the sampling kits. And so they're going to see if they need to do further work on that. And so they've identified someone to do it and a target date. And underneath it is the response, or perhaps, you know, another customer would know this directly and put it straight in. But in our example, the manufacturer has stated that the swabs are stable when stored in dry conditions at room temperature and when used within the expiry date. So there's minimum amount of facility control in that example. Next slide, please. Most of the examples that we've seen have related to the technical things. But if you are doing sampling and you're going to also need to meet all the requirements of the management system. So an example with this would be the complaint system, where, you know, there's a brief line, and I'm sure you all have processes already for this. And in most of the cases, I think the quality management system, you will have governance structures, you will have a lot of the information. It just might not be in accessible or quite in the same detail as required. So please do check all the management requirements. Next slide, please, Emily. Now, in this example, we've identified that the customer thinks they're partially compliant in Comp 02 procedure because they have a procedure that covers complaints, but it doesn't cover feedback, and it doesn't cover complaints that are not from patients. So they've identified that although initially it looked to be okay, there's some things they need to do. So they're going to review a revised procedure and processes to make sure that they do cover all those scenarios. I've identified someone to do it and by a target. Next slide, please, Emily. So really, what I would suggest is that you have a good detailed look at the standards that are relevant to you once you've bought them off BSI online. They're copyrighted and BSI have that. What I would suggest is that you you have a look at the details in the standards systematically, and on what the content is there in detail, because that's the best way to get through systematically what you've got in place and what you haven't. But do make this a useful thing to you. We put it in place, and at pre-assessments for our usual customer processes, we expect them to just do their own gap analysis. But we did think if we could help you by generating a form that you would have and have some training, albeit very basic, about what to do, at least it would be helpful to you. So the intention is that we're sort of explaining it so you have an understanding of what's required for this stage. Just state what you've got in place, and make sure that you're clear to yourselves what you're doing, because at the end of the day, it's your gap analysis. You're doing it so we can have a look at it, but the intention is really that it's your plan and your process to get you through this next steps to accreditation. And make sure it's got enough detail in for you to understand what steps you need to take and who's going to do it by when. And realistically, it's a very useful management tool for you to progress things. What I think is that we don't want you to send revisions of things. Once we ask for you to send it to stage 2, we'll want to see it again later on, but please don't, every time you update it, send it on to us. Thank you, Emily. Are you doing this bit, Louise, now?
Yep.
Thank you.
Okay, Emily, would you mind bringing up the form on the website? So that's actually version 1 of the form. We do actually have a new version. It doesn't matter because it's very little different to this. It's just got a couple of extra notes for guidance and a little bit of extra information needed. Now, it doesn't actually matter which version of the form you fill in. We've only just updated this form today, and apparently some people can see the version 2 form on the website and some people can't. It's all to do with what your cache is doing, but there is another problem with it which we're currently trying to sort out. But essentially, this is version 1 of the form, which I'll go through not in any great detail, but there is actually a version 2 form on the website. So essentially, it's got 13 stages required for accreditation on the form, and there are guidance for each requirement as to what you actually need to submit. And you'll notice that sometimes in grey, if you're already accredited, you don't actually need to submit, or if you're a sampling provider, you don't need to submit, for example, the IQC and EQA information. One thing that we really request you do is that you embed your evidence in this form. It makes it so much easier for us actually to link what you're supplying with which requirement we're actually reviewing at that time. So if at all possible, please do embed the evidence. If for any reason you can't do that, then just make sure that if you submit the evidence separately from the form, make sure it's very well indexed. So for example, number 1, please provide gap analysis, see document number 1 submitted, and actually identify your gap analysis with documents number 1, or something like that, just so that we're very clear on which parts of your evidence apply to which requirements. Okay, we can close that again now. Thanks, Emily. So there's an address on the end of the form, medlabs customer service at ukas.com. Please only submit your evidence to that form. We'll go into the deadlines shortly. Now, you may be thinking, well, I'm not ready to submit all this yet. Or you may think, actually, this bit doesn't apply to me. So, as I said earlier, you have self-declared as a provider that's taking responsibility for the end-to-end service. Therefore, there might be aspects in that form that you think you wouldn't be responsible for, but actually you are, because you need to ensure and evidence to us that it is meeting requirements. So like the example we talked about validation. So if you're working with another organisation, you're responsible for checking what they do, how they do it, and that they meet requirements as well. Okay, next slide, Emily. So you will receive the evidence submission back from UKAS once we've reviewed it. and we'll let you know whether you have met the requirements or if we need further evidence. If we do need further evidence, we'll request that that is submitted back to us within 7 days. If we identify any gaps that need further evidence, then just make sure that those gaps feed into your gap analysis and manage it that way. Now this is misworded, granted is the wrong word. If your evidence is accepted and you've met the stage 2 requirements, then we will inform DHSC and you will remain on the gov.uk website as an approved provider. Once you've passed stage 2, we will then propose next steps, including when you will be receiving your initial assessment. Next slide, Emily. So in terms of timescales, the Department of Health and the legislation have edicted the timescales. So the deadlines for submission of evidence are written into the legislation, and there's nothing that UKAS can do about that. That was not our decision, and it is set in stone. So just to make you will, if you haven't already received an email, you will receive an email stating what your deadline is for submission and giving you the link to the UKAS website where these two forms, the evidence submission form and the gap analysis, are. Just to clarify, if you're providing for test to release TTR, you need to complete stage 2 by whichever is later of the 18th of January 2021, which of course is past, or 4 weeks after completing stage 1. In other words, submitting your self-declaration and your UKAS application form 4 weeks after that. And in order to continue to provide tests for general population testing, you need to submit your stage 2 evidence for general population by the 31st of January, or again 4 weeks after completing stage 1, in other words submitting your self-declaration and your UKAS application. There is a risk of removal from the DHSC published list if you don't submit your evidence within those stated timescales. So as I was saying, you know, some people are coming back to us and saying, well, there's no way I've actually got this ready. I've only just been informed that I'm approved, and now you're telling me I've got to submit tomorrow. What we would say in that case is submit as much as you can. Have a look through the form, see what you've got already. Hopefully you will have started your gap analysis well before now. And submit what you can. We will then come back to you and say, well, you know, you haven't submitted X, Y, and Z. We still need that, and you know, possibly from what you've submitted, we need a couple more things as well. And then you'll get another 7 days. So if we come back to you with needing more evidence, it will always be that we request that further evidence after 7 days. So going back to, if you're not able to provide all of your evidence, as long as you get that evidence to us by the second submission, you will remain as approved on the website. But obviously just bear in mind that you run the risk, if you can't submit it all the first time round, if you don't submit it all at the second round, then you will be removed as an approved provider from the published list. So if further evidence is required after the second round of submission, then DHSC will be made aware of the status. If successful, you'll be maintained on the DHSC published list, but if you haven't met the requirements after 2 stages of evidence, then you will be removed from the approved list at this stage. Okay, Emily? So lastly, support, a couple of email addresses. We've got covid@ukas.com with any queries. Also, for advice on the interpretation of the regulations, please do contact DHSC as opposed to UKAS, and the email for the DHSC is there. Also review the information on the UKAS website and the DHSC website for supporting, you know, information and frequently, there's a lot of frequently asked questions certainly already on the UKAS website with answers. And as I say, recordings of this webinars will be sent to you, and there's another 2 recordings, 2 sessions on Friday. Now, in terms of those 2 email addresses, please be aware that both ourselves and the Department of Health and Social Care are doing our absolute best to answer these emails in a timely manner. But you may you may appreciate that we've had a lot more applications and self-declarations than I think DHSC were expecting. We're doing our very best to answer those queries in a timely manner. If you don't get answered within a couple of days, please send an urgent query in again, but we are doing our absolute best. Okay, Emily.
That's great. Thanks very much, Louise. So we do now have plenty of time to address the questions. So we can work through these one by one from the top. And Louise, Julie, or myself, whoever's best placed to answer these, will get to them. So just a reminder, Louise and Julie, the participants can't see the questions. So as we go to answer them, could we please just read them out in full so that everyone is aware of the question and then the relevant answer. So we can start with Sue.
Okay, Sue's asked, once we have self-declared, when would we expect to be listed on the DHSC site? I've yet to see any addition recently, despite self-declaring 3 weeks ago. Sue, I'm not sure if you've already emailed the DHSC email address, but you need to email them if not. If you have emailed them, I appreciate they may not be responding that, immediately, but essentially, it's best to contact them to find out what the delay is. It may be that we've reviewed it and asked for more information. It may be that they've not yet asked you for the further information, but essentially that's the best way of finding out where you are in the process. It might be worth clarifying, by the way, I did get clarification of this morning, that if you have declared and, if required, submitted and had accepted a UKAS application, you can start doing the testing. So it doesn't actually stop you doing the testing if you're not on the approved website, but just as long as you have submitted an adequate self-declaration, filling in all the questions, and you've had a UKAS application, if applicable to you, accepted. Sahar, are there any companies that can help with consultancy? Who can we ask? I haven't actually heard of any. It's not something, again, because we can't provide consultancy, that we would give that information out anyway. I'm sure with the scale of this operation, there will be companies that can provide consultancy. If you look, for example, on the web for ISO 15189 accreditation consultancy, or 17025, or point of care testing accreditation consultancy, I'm sure there are plenty of them out there. But that is an interesting question, and but I don't actually know the answer, and we couldn't actually give you that information even if we did. Now I've looked through a few of the questions, and there are quite a lot on the insurance in terms of medical. Lisa's asked, for doctors, is our medical indemnity enough? Ali has asked, please define adequate liability insurance. Are we referring to medical malpractice insurance? And I'm pretty sure there's a couple more questions down there as well. I think similar questions have been asked in other webinars. I'm not sure if there is a frequently asked question and answer about this yet, but I think we will look into it, and if we can provide information, we will. As I said earlier, the key thing is for you to actually look through what your insurance or your proposed insurance is covering. What are you actually doing? What activities are you doing? Does your insurance cover it? So I can't answer that immediately. If we can answer with the frequently asked questions, we absolutely can. Okay. I'll answer a couple more, then hand over to Julie. Marissa has asked, as sample providers, do we need to purchase the ISO certification mentioned, or is this granted by the laboratory we use that is fully ISO accredited? You absolutely need to buy that standard, Marissa, because each copy is copyrighted to the organisation that buys it. So your laboratory cannot share that with you. If they do share it with you, they're going against copyright regulations. So you do have to buy that yourself. And Kate has asked, ISO standards is usually for clinical laboratories. Are these standards only relevant for the labs carrying out testing and analysis? No, both 15189 and 17025 are absolutely relevant to the organisation that's carried out the sampling. So even though not all of the clauses apply, if you look, for example, at 15189, most of the clause 4s will apply, because that's all about your quality management system. Some of the clause 5s will apply because that's about your technical procedures, and there is a section in there about sampling and instructions for sampling. And there are other aspects in there, as Julie mentioned, like the environmental, like validation of IT systems that still apply. and Kate has also asked, are these all applicable for general testing or just TTR? I'm not sure which part of the talk you're talking about there, Kate. Can you just put further information lower down in the chat about what particularly you're asking? But I saw another question lower down about why do we need to comply with this standard? CQC is much more applicable. These standards aren't designed for sampling organisations. Well, actually, we've got, even though we haven't accredited purely sampling organisations, for a lot of our accredited testing laboratories, they are also accredited for sampling. You know, that's very, very common in UKAS. So, you know, a lot of these standards, a lot of the clauses do apply to sampling. You perhaps need to think a little bit outside the box sometimes when you read a standard as to, it may say laboratory, but actually it may well apply to you as a sampling provider as well. So they absolutely are applicable to sampling. Shall I hand over to you, Julie?
Yes, yes.
I think I've probably just about covered Alexander's question there.
Karen, how would you do a competency assessment if a GP practice is a single GP and only a GP is taking the swabs? Oh, Emily's going to answer that one.
No, that means actually we're answering it, Julie.
Oh, sorry, I do apologise. Okay, so I do appreciate it's more difficult if you're working alone. However, you will have some objective evidence of competency in that you are assessed for your medical practice. You would need to collate some evidence to demonstrate that your ongoing competency through CPD and things that you have done that work. For example, if you have good evidence that you regularly take samples, they're always valid. I appreciate it's hard if you haven't got any independence to do that. Perhaps you could ask a colleague to assess you. We're not going to specify the specific evidence of competency. It can be gained from a number of places, but it's what's suitable for the level and what is accessible and sensible for that activity.
Can I just chip in there, Julie?
Yeah, of course.
Because it's a question that's often asked us of a lab. You know, if how does someone sign it off the top level, you know, person in the laboratory? And that's where the objective criteria and objective evidence come in. Admittedly, in your case, I can see it's a little bit more difficult. But you know, what as Julie says, what training and experience have you got? How long have you been doing this type of sampling? Is it covered in your annual your validation appraisal, etc. That kind of thing. So it's thinking a little bit outside the box about what do you need to demonstrate that you're taking samples properly. Back to you, Julie.
Yes, yeah, I'm just looking now. I do apologise, I'm slightly lost. It keeps
rotating. Right. Well, actually, I think I missed one from David Black. For TTR, is PCR only accepted, or will LF lateral flow devices become acceptable now in the future? And I think someone's asked a similar question later. Julie, correct me if I'm wrong. I think only PCR has been acceptably validated so far. I think there are point of care devices. Well, point of care, depending on we'll go on to exactly what point of care is. But I think there are other methods that have been validated. It's all about does it meet those criteria for sensitivity, specificity, etc. for TTR. So I'm quite sure. Well, you know, absolutely, they're still working on the lateral flow devices, and I wouldn't be all surprised if some of those are approved as in meet the criteria at some point. I'm sure they're still working on them. I hope that answers the question.
Kate, didn't we submit most of the information for our self-deck? I had to submit all the information online. Do we need to duplicate this? Now, what perhaps you don't appreciate is that the self-declaration is the DHSC approval system, and you've applied for that. You've also applied for UKAS, which is a separate entity, and we're going to assess you by looking at things in a different way. And similarly, you will have done things for the PHE if you're reporting. And each one of those bodies has to do the job to make sure that you go through the right processes within them. So most of our assessment managers will have no idea what you've submitted on your DHSC information. In addition, lots of people we've realised are rapidly changing what they want to do. So when you apply to UKAS, you need to fill in the self-declaration as what with the information that is currently relevant. Of course, if you have changed that, you need to let the DHSC know. But our process is totally independent in terms of assessment. So we don't see what the PHE do for their reporting. So it's not linked together in that way. So unfortunately, you do need to submit everything as required for the stage 2. And it's more information than you needed to provide for the first stage. Again, this one's on insurance. Our liability insurance provider says the sampling activity comes under doctor nurses who have professional indemnity to cover the administration of pathology tests and seeing patients. Does this cover the scope of activities if we also have public liability for the team? If it covers the activities that you are wanting to do, yes. If it suddenly had POCT testing, for example, it might not be covered. So it does depend on what you're actually doing. It sounds like it possibly does, but just be sure that it does cover everything that's relevant in your work for this. Sue, single occupational health service, facilities and cleaning, has attended workplace for testing. How do I evidence this in varied site locations? We've got quite a lot of people who do mobile testing or testing that's actually capable of being off site. I think what you probably have to have is a standard process that you use to ensure that that meets requirements and that you apply that at all the new locations. I think if you're just doing sampling, it's probably fairly limited in terms of the facilities, but you wouldn't want to do it in inappropriate facilities. So I'm assuming that when you go and take on the work to do, a school or an occupational health service or whatever, that's part of the process, that whatever is provided is sensible. And what we would assess you on is how you assess that and what you're looking for, what are the criteria that you need.
Shall I take over for a little while, Julie? As Adair has asked, is TTR done via rapid test only or via lab PCR as well at present? Actually, it's mostly, the vast majority is by PCR because it's a more sensitive, specific test. I think there is a rapid test that meets the criteria, but I couldn't absolutely swear by it, but it's mostly PCR. Christina, if an organisation does sampling only plus sampling and point of care, do we need to apply for all 3 ISOs or just 15189, 22870, the latter? So yeah, 17025 isn't relevant if you're doing point of care. If you were doing sampling only, you could do 17025 or 15189, but if it's sampling and point of care, it has to be 22870 will only go with 15189. It's an additional addendum to 15189. So yes, you have to do those 2 standards. And secondly, if sampling is subcontracted, does contractor need UKAS accredited? That's a really interesting question. I know there's been a bit of batting back and forth between UKAS and the DHSC about this sort of scenario. Essentially, it depends on who's taking responsibility for the end-to-end process. If you are and you subcontract the sampling, then you are required and responsible for ensuring that that sampling organisation meets the requirements of 15189. The easiest way for them to do that is for them to be accredited themselves, because then you can just essentially say, well, they're accredited, therefore they meet the requirements. If they're not accredited, it's quite difficult for you to actually demonstrate that you're competent enough to check whether they're meeting the requirements or not. So I would say that the easiest route to go down is for both to be accredited. It's not absolutely essential from an accreditation point of view. The other thing to check is to actually check with the DHSC and see what their view is actually in terms of that sort of model and whether they require both organisations to be accredited or not. Tahira, does the gap analysis need to be complete before UKAS accreditation is given? Absolutely. The gap analysis is really the start of the accreditation process. It's for you to compare yourself against the requirements of the standards, where you are against the requirements and what you need to do to meet the requirements. So there's actually a long way to go between gap analysis and accreditation. The gap analysis is part of stage 2. We will then do an initial assessment where findings may be raised, and you will need to clear those findings before we will actually grant accreditation. So as an independent clinic, occupational health, how realistic is it to achieve gap analysis in a very small independent organisation? We get asked this a lot for all sorts of organisations from a UKAS accreditation point of view. The fact that we are essentially streamlining and cutting down the costs of accreditation for this process is partly to accommodate you know, organisations from you, because it is quite common that we've either got, you know, a single GP or an independent clinic actually going through this process. I mean, obviously you've got to weigh up the pros and cons about whether it's worth your while getting accredited. You know, is it worth you going through the costs of accreditation and the work involved in order to be able to be approved to provide this COVID testing service? So yes, it is absolutely possible, but it is up to you, obviously, to ascertain whether it's worth your while or not. Lisa has asked, it would simplify everything if you could produce a sheet of exactly what's needed for a GP, as this is a very complex process. Lisa, we've actually cut this down as much and provided as much guidance so far as really we are able to do. It might sound like a really good idea for us to define what you need to do, but because there are so many models of how organisations and individuals have applied for accreditation, you know, there are lots of possibilities and models about how this is actually being managed. So it wouldn't be one document saying this is what you need to do. It would be a lot of documents, and indeed it's up to you to justify to us essentially what you're doing, which requirements apply to you, and how you meet them. Ali, how far do you need to progress on the gap analysis before accreditation is given? Does everything need to be green? Ideally, yes. However, that won't be enough to grant you accreditation. As I said, we then will actually come and do an initial assessment. And obviously, the closer you've got to everything being green, the less likely it is that we will actually raise findings that you still need to provide evidence for, and that accreditation can be granted fairly seamlessly. So it doesn't have to be absolutely green by the time we get to the initial assessment, but it's obviously to your benefit to actually go down the route as far as you can to make sure that you are compliant with all requirements. Sahar, what is the minimum for stage 2 to achieve by January the 31st for a clinic sampling, GP taking samples and sending to lab, and GP doing point of care in the clinic? Well, when you look at the stage 2 submission form, you can see which ones apply to sampling and which ones apply to both lab and sampling, and essentially you need to, if you're doing point of care, when I say laboratory, I mean a testing organisation. So if you're doing both sampling and point of care, you actually need to complete all the questions in the stage 2 submission form. Victoria, I think you added to your question. I'm hoping I've answered it. If not, feel free to ask another question. Kieran, can you clarify that rapid antigen testing in clinic applies as point of care testing? The definition of point of care is essentially, is it testing that is carried out at the patient, next to the patient, very rapidly, and is the result given to the patient? You know, when I say patient, you know, I know it's not exactly a patient, but is the result given to the individual there and then, and does it affect their immediate management? So if that is the case, then yes, it classes as point of care testing. So therefore you would need to do ISO 15189 and 22870. Occasionally, a rapid antigen testing could be used in a laboratory setting, and it wouldn't be point of care. So even though you'd think that's a point of care device, actually it's not done next to the patient. The result isn't given immediately to the patient, and therefore it will be hours or days before that result will actually affect the patient management. So that's how you need to think about it. It's not necessarily what kind of test device is it, it's how the result is actually carried, how the test is done, and how the result is used. Can I just answer this and pass on to the next one to you, Julie? Tahira, if you are just doing sampling, do you provide a list of UKAS accredited labs for PCR testing? You can very easily look on the UKAS website and do a search of accredited organisations for COVID-19 PCR testing. But bear in mind that that currently the accreditation schedules don't specify whether that testing is for general population or for test to release. So that would be something, if you found a lab and you thought you wanted to use them, then obviously get in touch with them and find out for what purpose they are doing that testing. The other requirement is that they've got to be on the approved list themselves for you to use them. And of course, don't forget that a lot of labs are going through the same process of you, that they're not actually accredited yet, but they're going through this approval process. And as long as they're doing that, they are on the approved list, then you can still use them even if they're not yet accredited for the PCR testing. Okay, I'll hand over to Julie.
Okay. Andrew, can you give us some estimate of the total cost in pounds sterling involved in going through this part of the process and the whole process? We're a very small private general practice. I think this information is in the frequently asked questions. I'm not sure about that, but the stage 2 is likely to be 0.5 days. Emily, do you want to add to that? Do you have more information on that?
Yeah, so this is a common question and it does come up a lot. At the moment, based on all of the submissions that we've received, and this is what has been said on the former webinars as well, based on all of the information received, we are going to put together some estimated costs for lots of different types of service provider, depending on whether you're doing point of care or just sampling and what kind of model you're using. It's very difficult to give the indicative costs of the initial assessment because so many things really contribute to those costings. But yes, for the stage 2, there is a flat fee of half of the day rate. The day rate is £1,213. So I think it's £606.50 is the charge for stage 2. And this charge is ultimately to reduce the time that we're spending at stage 3. So if you haven't had any costs before that have shown that stage 2 is included within stage 1, the model has changed slightly. So stage 2 is now chargeable, but the costs of the initial assessment are going to be reduced, and you will have access as soon as the costs are available on the website. We will circulate all of those, and we're hoping for them to be done in the coming days. And also on an individual basis, you will be receiving an estimate for your particular case and your stage 3 assessment. So still a little bit up in the air and more work to do, but hopefully that gives you an indicative answer for now.
Thank you. Tiara, can you give us the ISO standard number we need to buy? So coming back to the talks, we've talked about ISO 15189, which is the medical standard for testing. And the adjunct to that, if you do POC testing, is 22870. And the standard that you could use as an alternative if you're just doing sampling and no POCT, and that could include testing with no POCT, is 17025. And so when you get the slides, that's detailed on the slides. We operate in England and Wales. Do you have any knowledge of this would apply in Wales, or is planned to do so in the future? As far as I'm aware, the DHSC have said this is for England only. However, if you are providing a service to the England part of the country, so if you're going over the border and sampling and it's being reported to the PHE, then obviously you are going to have to fit in with the requirements for England. And lots of people are using labs that are not in England, for example. So those labs will still need to comply. Let's see here. If we have CQC structure as a GP clinic for complaints and adverse events, can we quote this in the gap analysis and respect to COVID testing? Well, this is very relevant, obviously, to your already existing processes. So it's a case really of, yes, you can add that in your gap analysis and say you've checked to see if there's any other requirements in the standard. For example, as incident reporting and things like that, you're going to have to include the PHE now. I'm not sure that would be in your current statement on how you deal with complaints and adverse incidents. So it's a case really of just looking to see if there's anything extra you need to do, but it is likely you've got a system that covers the majority of the clauses in there. Nazia, do we need to buy ours as standard in addition to the UKAS registration that we have paid? Yes, this is right. You do need to purchase it. It's a copyrighted document, as Louise had said. So yes, it can't be transferred between different organisations. So you do, I'm afraid. Hannah, if we're planning on sending medics on site to conduct bulk antigen testing and provide results on the spot, does that mean we are end-to-end testing? Which ISO do we need to complete, and how does this impact on reporting results? So this is an example where you have taken responsibility for the sampling and you're doing point of care testing. So it's ISO 15189 and 22870. Okay. The reporting requirements are listed in the standard, and it's a mixture of what you need to do for the PHE, what the requirements are, and there's quite a lot of information in the standard on that. Kathy, could you remind me, if we want to expand from general testing to POC testing, what would be the next step to take? Okay, I think it's fair to say that a lot of people have decided what they were going to do in December or maybe November, and things have changed. So make sure that you let the DHSC know if you change what you want to do. And also, if you've already applied to UKAS, you can change what, let us know of the changes. But if you get through and you're accredited, say in June, there's an extension to scope process that allows you to add on things at any point once you're accredited. That's a normal process for all of our customers. But if it's before you get accreditation, then clearly you need to know, because we can assess for everything that you're doing at that point in time. And also, if we wish to do PCR tests and we take the samples on site before sending these to a lab, does this alter the ISO standard needed? No, I think if you're just taking samples and sending them on, I think that's the same standard. ISO 15189 covers sampling and testing, so you'll be fine with that. Karen, the initial assessment process is a more detailed assessment. What we're looking at is the 13 stages at the moment to see that you're making good progress to meeting what is required in stage 2. And like I said, some of the critical things like the validation is for the appropriate test. But this isn't a full assessment. So at the end of the day, we will assess you and see that you meet the clauses that are relevant. At the moment, we're not looking at all the clauses, for example, and we're not looking at all of the implementation of how you meet that. So we are going to send as one example, but if you had 20 staff, for example, you might send one example in, but we would like to see that you've done it across the board and meet all the requirements as you need to. We will provide more information for stage 3 as time progresses. So don't feel that you're alone in that. Is the latest deadline on the 31st of January? I think we've already answered this to an extent. It depends on when you actually applied and what you applied for. So we are providing an email with the date in to people. But Louise already explained that it's the date you submit to the DHSC and the date your application for UKAS was accepted if you applied in January. So if you applied later than the original deadlines, you get a bit more time. But the 18th of January for test to release was the original date, and the 31st of January for general testing, but you get 4 weeks after you applied for both of those things, whichever is the latest date. Yvonne, whilst there are outstanding compliance on our gap analysis, can we still be accepted to continue on the gov.co website until we work out towards TTR? Again, if you provide enough evidence that you're making progress, there's nothing critical. If at the end of the day, like I say, the validation didn't demonstrate that you met the test to release requirements, then clearly we need to sort that out pretty quickly. We couldn't progress with an inappropriate test. But realistically, we are looking to see that you're in the right ballpark and that most things are getting done. But no, we don't expect you to have completely finished everything in the gap analysis at all. Arun, where can we get the gap analysis from? The form is going to go, Emily's going to say.
No, I was just going to say that I will circulate the latest links to the website to everyone shortly after this, alongside a copy of the slides. So yeah, don't worry, the latest versions of the forms will form part of that.
Yeah. Alexander, are the PHE reporting requirements the same for test release as for general testing? There's quite a lot of overlap, but they're not the same. You do need to look at both of them. They've got timelines and things in for test release and the reporting to the PHE. So please do check. If you're doing both, you really do need to keep up to date with what the DHSC is saying, because we will assess at the time if they change the requirements or they add things. You do need to know about that. So just keep an eye and double check. Nazir, the healthcare professionals who have previously taken swabs also have to show a log of testing and competency. I think if you're already doing it, you're very likely to have some records already and be able to demonstrate testing, training and competency easily. And if there isn't anything, then it's probably fairly easy to get that together. So yes, you will need to provide that. Jack, if we are an established CQC diagnostic and screening provider, does this process need to be additionally validated by the CQC? The legislation changes were that UKAS takes over responsibility for COVID testing and sampling. So that's why we are needing to cover that portion of the work. If you're doing other things that are not related to COVID, then obviously CQC are going to look at that aspect of it still.
Do you want me to take over for a bit, Julia?
Yes.
Voice going.
Sorry.
Hazel, can we offer test release until we receive UKAS approval when we currently have DHS approval? No, as long as you've got DHSC approval, you can offer test release and general population testing. Matthew, the lab I use for general testing is not registered for TTR, therefore require the use of a different laboratory for TTR. How should this be accounted for? Well, needless to say, you need to find a laboratory that is approved and is able to offer TTR. The easy way probably to go on the government approved list, and then you need to inform if anything changes between what you've self-declared for and what you apply for, then do let both ourselves and the DHSC know of what that change is, and then we can review what you're planning and doing and make sure that that's approved as well. Sarah, can I clarify that the requirement is to complete the gap analysis form, not to meet all the endpoint standards, but to demonstrate working towards them? Yes, I think Julie's already covered this. Yes, absolutely. If you met all the requirements now, we could more or less accredit you now. But no, we don't expect that anyone meets the requirements now. We expect that you demonstrate sufficient progress towards meeting the requirements, which is what this stage 2 is all about. But no, for everything else, what we need is your plan. What do you need to do? Who's going to do it? And by when? Hazel, can I have the recording for the earlier webinar for sample collection providers? I'm not sure if you mean the one that was held on Friday, because from today's point of view, this is the webinar for sample collectors. The other one was for testing. Maybe you could just write another question, just clarifying, do you want the one that was the recording of the one on Friday? Chris, I have submitted to DHSC self-declaration form and also submitted my lab reports for the TTR. I then received an email to say that I'm overdue on my stage 2 submission by 1 day. I wasn't aware when the deadline was, as I was waiting to join this today to see what had to be submitted. I'll get that in as soon as possible. We'll only be starting today. Yeah, I can only apologise for that, Chris. I'm aware that there is some delay in DHSC informing applicants that they're actually approved, and then I know this deadline is upon you. I think the deadlines were on the website anyway, but I could quite appreciate that you know, it would have been much easier if you'd been approved before and informed of the deadlines. But yes, get in what you can as soon as possible. Purinka, does EQA apply to point of care testing? Yes, absolutely. Most of the requirements in 15189 and 22870 apply to point of care testing. And that includes EQA. Yes, what interlaboratory comparisons schemes do you participate in? And that's all to demonstrate that your point of care testing is essentially giving comparable results with other providers using that testing method and providing that same testing. Can you estimate the full cost of assessment? The estimates all seem very vague. I think we've already answered that one. If there isn't a frequently asked question already on the website about that. I know one of the webinars on Friday that was discussed, and that we would provide rough estimates for different sorts of typical scenarios about how much it's likely to cost you. We can never be absolutely definite about that before we actually do what's called the contract review. So it depends on what your service is, what you've applied for, what's your scope. We will do a contract review and justify what effort we need to actually do the initial assessment. As we've mentioned, the stage 2 is a standard half day, so that's already been agreed. What we haven't agreed yet is how much effort will be required for the initial assessment, and again, that will depend on what you're doing. So for example, if you're doing point of care testing as well as sampling, that will cost you more because we need to do more assessment. Ashraf, I purchased ISO 22870 point of care from the ISO website. Is this the same as 15189? No, ISO 22870 is an addition to 15189. It actually tells you that in 22870. So you need 15189 and 22870 if you're doing point of care testing. Apple, we have applied for TTR and provided an independent validation given by the lab, or provided the independent validation, which is also used by other private providers and already on the list. Who do we contact best to follow up on this so we can move to second stage? We are not getting any response. I think what you're asking is, what do you do if that lab isn't providing you with that data? I think all you can do is submit as much as you can of the stage 2 declaration and say you've contacted the lab, you're aware that you need to provide that information, and we'll come back to you. And as part of our additional evidence requirements, we'll say, well, we do need this in 7 days' time. I mean, don't forget, of course, that you are the laboratory's customer, and they hopefully want to keep your custom. And if they want to keep your custom, they should know that they need you to provide you with this information.
Just to follow up on that one, Louise, in this instance, the validation has gone back to the DHSE. And there are some delays. If you are awaiting to hear a response from the DHSE, I'm really sorry, but from our side, we can't expedite that. It has to be them who are chased. If you've sent them information and you're awaiting their response, please do feel free to chase them again urgently, but just bear in mind the volume of inquiries that they're receiving as well. And we apologise from both organisations at the moment for any delay.
Oh, yes, I misunderstood the question. Yeah, thanks, Emily. Kalpesh, hi, for the medical director contract requirements, does this have to be an employment contract or just a contract, self-employed contract? If a contract is not required, will an agreement suffice? Probably it needs to be a legal contract. If you think about it from a point of view of if that individual gives an incorrect medical advice or statement, you are responsible. If you get sued, you need some avenue to be able to actually deal with that situation. So look at it from that point of view. Unfortunately, it's not a nice way to look at it, but that's what you need to bear in mind. As an end-to-end provider for using a lab, how do I decide whether 15189 or 17025? That's a really good question. First of all, check if your lab is accredited or if it's applied for accreditation. If so, which standard? Because if they're doing 17025, it would be very difficult for you to do 15189. It's potentially possible the other way around, but it's probably best to stick with whatever they're accredited for. And the other thing probably to take into account, Julie knows more about 17025 than me, but there's more requirements for clinical advisory services in 15189. So if you're providing a service that includes medical advisory services, then you should be going for 15189. Can you think of anything else to add to that, Julie?
Yeah, I mean, 17025 is a very generic thing, and typically, if you were you were just providing a result-only service, it's quite applicable. So quite often for STIs, a lab gets the result and sends it on. They're the intermediary. I think for most of these applications, it's not that. A patient is involved, they're getting healthcare input. So 15189 is probably the most useful for generic medical services, in that the DHSC are likely to expand what is mandated in the future. And if you've got 15189 and a clinical service, then that's probably going to be useful in the future.
Okay, Hannah, two of my questions missed, and then I think you've asked them again. I think it's just because of the volume of questions, Hannah, that we haven't always answered. If you've asked more than one question, it doesn't always come up on our list consecutively. And I think, Julie, you've already answered those two from Hannah's below about sending medics on site to conduct bulk antigen tests. And if we wish to do PCR tests and take the samples on site before sending these to a lab, does this also the ISO needed? I think you've already answered those. Yeah, good stuff. Marissa, how do you ensure that self-administered samples are collected in an adequate standard? That's a really good question. It's a DHSC decision that these don't come under accreditation, so it's not really a question we can answer. So you obviously still have to self-declare if it's self-administered sampling. However, if you're not playing any other part in the process, for example, you're not doing the testing, you're not taking the samples, it doesn't have to be accredited. What we will be assessing is when we assess the laboratory that actually uses those samples, that receives and tests those samples, we'll be assessing how they make sure that the samples have been taken competently and properly. So, for example, what sort of instructions do they provide? What sort of checks do they do on the samples when they come back in terms of is the sample adequate? Has it been correctly labelled? All that kind of things. Can you think of anything else to add to that, Julie?
No, I think that's right, really. There are going to be examples where people do more than just send out a kit. If you're involved in making a decision on the adequacy of the sample at the point it's taken, then obviously you need to be included in this.
Can I, as a CQC registered practice, I'm bemused by that so much of what is required for CQC seems to be required for UKAS. We perform multiple sampling from all parts of the body, and why is it that this has to be credited and not the other processes? Obviously that's a DHSC decision. I mean, I don't know for a fact why that was. I'm assuming it's because, this is potentially a big money maker, and I think there was the potential for all sorts of odds and sods to jump on the bandwagon and actually do this testing because of the opportunities there. So I think the DHSC basically just saw this as a significant risk, a higher risk than perhaps the other sorts of sampling that you're doing. So I'm presuming that's why. Kate, we are registered already for diagnostics and our insurance covers this. Is this sufficient? Again, without actually looking in great detail, Kate, we couldn't say for sure. It certainly sounds it, and as Julie says, it's just making sure that your insurance does cover all the activities that you're doing and applying for accreditation for, and that you've got significant, cover in terms of financial amounts. Heather, local authorities are commissioning organisations to offer lateral flow tests for asymptomatic testing and paying providers a cost per test. This doesn't seem to fall into UKAS scope at the minute, despite being a similar activity. Is there a plan to address this? So I think whichever organisation is actually essentially taking the money, I think would still come into this process. No, actually I might be wrong. I think I've heard actually where it's edicted that this will take place. I'm not absolutely sure. Yeah, sorry, Heather. Yeah, I'm not actually sure. I think that's definitely a DHSC question. I'm not sure if the organisation actually doing the sampling and testing need to be accredited or not. It would seem reasonable, but I have heard something, and presumably you have as well, that doesn't come under this process. But it's not a question I can answer. It's definitely a question for DHSC.
I understand that if it's government-funded work, that is outside of this. But there will be some assessment of the suitability of those providers, by the local authority. So that would be relevant to them.
I know we're nearly up for time, and I know Emily's going to step in very shortly. Alexandra, I would imagine the number of applicants is an order of magnitude greater than anticipated and presents, given the requested timescales, as much of a problem to UKAS as for sample providers. With this in mind, could UKAS not request a legislative amendment to give UKAS and sample providers more time? They could just add a clause. Not up to us, Alexander. We're actually pulling in resources from left, right, and centre to actually be able to complete this work in line with the timescales that we've been told about. So again, that's not up to us, unfortunately. Chris, how do we gain the ISO certification? I paid for the ISO on their website. So you're not talking about certification, you're actually talking about the standard. And if you've applied for BSI online, it's generally that as soon as you paid, the PDF actually gets downloaded. So it's a question for whichever organisation you've actually bought the standard from. Sahar, in terms of worth, how much is stage 2 and stage 3? I think we've answered, but not answered that we'll make sure that there is something in the frequently asked questions. Felicity, I'm sorry I missed CR's question answer. If an organisation provides sampling plus point of care, do they apply for all 3 ISOs? No, if it's sampling plus point of care, it has to be 15189 and 22870, because you can't do the point of care standard 22870 with 17025. It has to be with 15189. So just to clarify, it's 15189 and 22870.
Yes, just keeping an eye on the time. Yes. I think Simon's question is a very good one, and probably one that everyone would like to hear the answer to if they missed it earlier. And then we do need to think about closing down. So Simon's question was, in the email we received regarding submitting evidence, it was stated that we needed to submit I can't see the email that you're talking about there, the email address, but then it said that you need to submit your evidence to medlabs customer service at UKAS.com. Very good point. Yes, please, to everyone, can you use and only use that email address for your evidence submissions to ensure nothing is missed, because we have a team who are ticketing all of those things coming in. So medlabs customer service at UKAS.com for any submissions. Louise, did you want to get to that last one from Richard? If a GP were not accredited, would it be illegal to carry out COVID-19 testing after June?
Yeah, well, I assume as it stands, yes, but I think that's a long way away. I think, well, although it'll come sooner than we think, that will be up to DHSC and the government, not UKAS. So I can't actually give you a straight yes or no answer, unfortunately.
Thanks, Louise. And I'm very sorry to all of those who we didn't quite get a chance to answer the questions for. We are out of time for this session, but as I said, we will be pulling all of these reports off. We will try to get back to everyone individually if we haven't had a chance to address your queries. If you do need anything further, please email covid@ukas.com, and we will follow up shortly after this session with a copy of the slides and the links that you'll need to the website, and further Q&As and the costings as promised will be available on the website shortly as well, and we'll let you know as soon as they are up. Thank you very much for attending. Thank you, Julie. Thank you, Louise. Apologies that we ran over ever so slightly, but enjoy the rest of your day, everyone.
Thank you very much.
Thanks. Bye.
Bye.